Okay, so it's a pleasure for me to talk at this nice meeting organized by Nestlé Health Science. This is the old information when Professor Renan Shamir, who unfortunately for situation in the Middle East was not able to join us, but I know that he's joining us online. So all the best to him. And I will talk, here are my disclosures. And I will talk about CoMiSS data in presumed healthy infants. How does this strengthen our clinical practice? Where we are at the IACI meeting, and this morning, Alexandra Santos presenting IACI guidelines on the diagnosis of IgE-mediated food allergy with impressive 63 co-authors. I know, Karina, that you are one of the co-authors. Very impressive. But this quote comes from the editorial, which was also wrote by Alexandra. Infants and young children are particularly vulnerable from a nutritional standpoint, and so it's vital to ensure that a robust diagnosis is made in a timely manner to mitigate any effects on growth and avoid the development of aversive eating behaviors. A robust diagnosis. Many of you, if not most of you, are allergists, so probably you are already seeing pre-selected group of patients. But it's very important that those who are referred to allergists are really well selected. You already heard about CoMiSS and the 2022 update. We know that recognizing any kind of allergy is challenging, but especially recognizing non-IgE-mediated cow's milk allergy in infants is challenging. The CoMiSS is a tool to raise awareness of symptoms related to cow's milk, and CoMiSS values are already available for both healthy and symptomatic infants aged 0 to 6 months. What is not known are the data for CoMiSS, and they are still needed in presumed healthy infants between 6 and 12 months old. And therefore, within the CoMiSS, we started the project, and the objective of this study project was to determine CoMiSS values in presumed healthy infants who have completed 6 months and are up to 12 months. And those in patients within age range when the diagnosis of cow's milk allergy is often established. You have already seen the CoMiSS study group because Ivan van den Plas already introduced the group, and together with some collaborators, and we were working on this project, and my young colleague from our department, Mateusz Jankiewicz, is the first author in this project of the manuscript, which is now under, I would say, the final stages of the review in a European Journal of Pediatrics, in the final stages, because just yesterday I got a message from the editor that it's only minor revision, and really minor. So we have done a cross-sectional study. It was international multi-center study. Participants were presumed healthy infants aged 6 to 12 months attending well-tried clinics. Exclusion criteria included preterm delivery, acute or chronic disease, therapeutic formula, the use of therapeutic formula, the use of dietary supplements, or the use of any kind of medication. And the CoMiSS healthcare professionals were asked to fill in the questionnaires, and interviews were, of course, conducted in native languages. Here you see that in total we included over 600 European infants. They came from Poland, Spain, Italy, Bulgaria, Czech Republic, and Belgium. And on this slide, I am showing you the data median, 5th percentile, 25th, 75th, and 95th percentile of CoMiSS in healthy European infants aged 6 to 12 months. And as you can see, the median was 3, which is in line with what we saw in younger population up to 6 months. Here you see that the median was, CoMiSS was highest at 6 months, it was 4, and lowest at 12 months, which was 1. So it was declining, which is opposite to what we saw in younger children when it was increasing. On this slide, you will see there was significant difference across age groups, in particular between infants 6 months versus 10 months and infants 6 months versus 12 months. We also looked at the effect of gender and feeding type, and there were no differences across group based on gender or feeding type. And of course, we also looked at individual symptoms, and there were no differences for age, for crying, in the case of crying, for age, gender, and feeding. For regurgitation, it was no significant difference for gender or feeding, but there was for age. The same was for stools and for skin symptoms and for respiratory symptoms. There were no significant difference. I am sure many of you are familiar with this film, which I like very much. Some like it hot. And the famous sentence, "Nobody is perfect." It also applies to studies. There is no ideal study. Every single study has some limitations, including our study. And here I summarize the major limitations. So first of all, we used convenience sampling, which was used for pragmatic reasons. So participants were selected based on ease of recruitment, and of course random sampling would reduce selection bias. This was a cross-sectional study design, and of course this type of study design is subject to non-response bias. There might be potential differences between contributing and non-contributing infants. And the representativeness of a healthy infant population may be therefore questions. And last but not least, there was uneven cohort study. There was discrepancy in the size of cohorts from different countries. 47% of participants were from Poland. One explanation might be that this my very young colleague was very eager to include as many subjects as possible. But anyway, conclusions were from this study, from this cross-sectional study, that this study provides CoMiSS values for presumed healthy European infants aged 6 to 12 months, extending our understanding beyond the commonly studied age group, which is 0 to 6 months. And of course, further research is needed to assess the use of CoMiSS as an awareness tool for cow's milk-related symptoms for symptomatic infants older than 6 months. So what is next? Of course, we do have some plans, and one of them is to determine CoMiSS values in infants aged 6 to 12 months with symptoms suggestive cow's milk allergy or functional gastrointestinal disorders, something that we have done also in younger population. We plan to have this cross-sectional multi-center study with infants aged 6 to 12 months with symptoms suggestive of cow's milk-related issues. Of course, we will think about exclusion criteria, and as previously, the CoMiSS will be filled out by health professionals. So I did summarize you what is really new now, so new data when it comes to 6 to 12 months. And you have listened to my colleagues, and especially to Professor Ivan van den Plas, who are telling more details about CoMiSS. But every now and then, when I'm talking about CoMiSS, I have these questions. Are awareness tools for allergic diseases needed at all? And I know that some of you may ask this question yourself, and I did try to answer myself, and I hope it will be the start for some discussions that we can have later on. Well, why they may not be needed, and I was thinking about at least 3 reasons. First of all, risk of misdiagnosis and reliance on self-diagnosis. It was already presented here and many other meetings that there is a difference between self-reported food allergy and what is confirmed. So this might be one of the things that we have to think about. It may induce anxiety. Overemphasis on allergy symptoms may cause unnecessary concern. And the final one, medicalization of normal symptoms. I do remember that one of the reviewers, I think, Ivan, it was when we were on our Espegan cow's milk allergy, one of the reviewers said, not every person who is sad has a depression, and not every child who is crying has some kind of disease. And I think it's really important that making people too aware might cause them to seek medical treatment for normal reactions or minor issues. So these are some of the thoughts why this kind of tools may not be needed. But there are also reasons why awareness tools are needed. And here there were first one, awareness and education. I mean, it really helps the public to understand symptoms, aiding early diagnosis, which is so important. Overlaps with other conditions. We have already heard, and you have also heard from Karina on this famous paper which was published some time ago, but allergy symptoms indeed often mimic those of other diseases, and it's really important to understand what kind of disease we deal with, or maybe we deal with healthy children, which will be equally important. And finally, it really, in my opinion, contributes to efficient consultations, because when patients are more informed, they can communicate their symptoms and concerns more effectively. When primary healthcare professionals are better informed, they will refer the patients in much more, I would say, reasonable way and save time and probably also money. So a compromise approach and balanced approach is a user education, I would say, for optimal health management, integrating the awareness tool with established diagnostic procedures ensures a robust approach. And this brings me to almost final part of my presentation, and again to the Espegan paper, position paper. With the first paper, there was 67, I think, co-authors. Here we have 73 statements. I wish we could present this paper here, but I will not present the whole paper. And again, Professor Ivan van den Plas is one of the co-authors, and Professor Renan Shamir, who was supposed to be with